All right, good morning, guys. I'm going to try to make this a quick video. I always say that, and then I don't, right? So I'm going to talk about minimally invasive spine surgery briefly. This is my car talk, we'll call it, on the road talk, and then I'll have a talk where I show illustrations like I did the other day from my home computer. But first, I want to remind everybody that I am giving away a free Spine Center of Texas t-shirt. I know that's just so exciting. All you got to do is go to my Facebook page, Spine Center of Texas Facebook page. Go on the left. There's a spot that says join my mailing list, and just simply give us your email, and I'm going to be basically choosing randomly from those emails. And once you enter, every time I give away a free t-shirt or whatever I give away, I'll be drawing from that list of people. And so all you gotta do is put your email on there once, and I don't plan on inundating you with tons of emails. In fact, I haven't even really sent one out yet, but it will be medically related, nutritionally related, spine related things. So I'm just going to mention this. I've had a couple people ask me questions about minimally invasive surgery, and I'm just going to cover that real briefly. So minimally invasive surgery is something that has to be thought through. Okay, it's not a one size fits all set of procedures, if you will. Okay, so we don't just do everybody gets minimally invasive surgery. Now, some doctors don't have the training or the skill level, and let me tell you, I had to essentially, to some degree, teach myself, because I was doing minimally invasive surgery around in 2003 when it was relatively new. It didn't even really exist until the turn of the century. And of course, it's become more and more popular. I'd still say a lot of people don't do a lot of types of minimally invasive surgery. The first type of minimally invasive surgery was what we call a minimally invasive discectomy, and it's a great one. Most people are candidates for that one, and that is the biggest difference. Is what we used to do, and I'll try to show this on a spinal model whenever I have a chance to sit in front of my computer, is we would literally make a midline incision down your back in order to get to the bone, because we have to get to the lamina, that lamina bone that I showed you the other day when we were looking at a spinal model. So we got to get to that lamina. We got to remove a little bit of that lamina. We've got to remove that yellow ligament. Remember the yellow ligament I talked about? The ligamentum flavum means yellow ligament in Latin. We have to remove that yellow ligament. Then we can see what is called your dura, that cellophane thin, see-through, so thin, delicate covering of your cauda equina, which is the termination of your spinal cord. Again, refer back to that hour-and-a-half video if you really want to know this anatomy. We can move that out of the way. We can't move the spinal cord. Remember, the spinal cord ends at L1, L2, but below L1, L2, okay, your lumbar spine, which is where a lot of things happen, we can just very gently pull those nerve roots out of the way and then remove that disc, take that disc out. So the difference between a non-minimally invasive surgery, minimally invasive surgery, is the old way we did it is if we'd either do a laminectomy or a discectomy. I know some people would always do a laminectomy, and there's reasons for that, and they're not bad reasons. Laminectomy is when you remove the entire lamina, and discectomy is when you just remove a small piece of the lamina and then do what I said: remove the bone, remove the ligamentum, retract the dura, take out the disc that's pressing on the nerves. So whether you do minimally invasive or you do an open, what we call an open procedure, that part is the same. Everything I just described is exactly the same. There's no difference there. The difference is in the approach. The difference is in how you get to that lamina, okay? So in the old procedure, which has been around for decades, people were doing discectomies, all through the 1900s. I'm not sure when they were first described as a discectomy. I'm guessing, I'd have to look it up, probably somewhere in the 40s and the 50s, but again, I'm not 100% sure. But they've been going on for a long time. And what you would do is make a midline incision, okay, right over those posterior spinous processes. Remember that anatomy that I was showing you, the posterior spinous processes? And then you would separate the muscle, typically with a bovie cautery, with an electric knife that burns that muscle from the bone all the way down the length of the bone and down to the lamina, and separate the muscle, separate the muscle from the bone. And so for a discectomy, it's not that big a deal, but it is a bigger incision, and you're literally separating the muscle from the bone. And a lot of the pain that people have with any back surgery over the long term is from that muscle being burned off the bone. The muscle sort of is in shock. And with a bigger incision, you can remove inches on either side when you're doing a big fusion. That's when I think minimally invasive really can be beneficial, but it has to be in the right patient. is when you're separating, you know, a huge surface area of bone, many square inches of bone, of muscle from the bone, and that muscle is just in shock. It's sort of going, rah, you know, and that's where a lot, I think, the pain comes from in that first year, as that muscle reattaches, scars in. It doesn't reattach the bone. Most of the time the bone's been removed. It sort of reattaches to other scar tissue. And has to heal. So with a minimally invasive discectomy, the reason it's minimally invasive is because we stick a tube, a dilator. We don't go down the midline. I make my incision midline. That way, if the patient ever has to have a second surgery, I can go through the same incision, because it's so easy to simply make that midline incision, pull over just a bit, that skin's pretty mobile, and then go in from the side. But you come in at an off angle, and you stick a dilator down all the way to the area of interest. You use an X-ray to show you where the lamina is on both views, and then you slide tubes over that. So what's the difference? The difference is now, instead of burning muscle from the bone, I'm literally going in between the muscle fibers, and I sequentially dilate until I get to about 14 to 18 millimeters, which is a very small incision, and I haven't burned any muscle from the bone. I do my work through a microscope, which is absolutely the best way to do that. Using loops, I think, is just, I don't know how people do that. With a microscope, a number of things happen. You get 10 times magnification, and you have excellent lighting. The lighting is way better than any other lighting, and since you're using it, I use an assistant. My assistant can see exactly what's going on, rather than blindly holding a retractor on someone's nerves, which to me is crazy. But anyway, a microscope's absolutely the best way to, and that's how, used to be neurosurgeons used microscopes, orthopedists didn't. I'm an orthopedist. Where I trained, my ortho instructors, if you will, you know, my mentors, didn't use a microscope, but I was able to operate with neurosurgeons enough during my fellowship, kind of snuck in there and operated with them, to decide that I definitely wanted to use a microscope. I've been using a microscope from the day I started practice, and couldn't imagine not using one, especially for minimally invasive surgery. So you go down through that tube, you're operating through this tiny little hole, which, you know, takes some practice. It's tough at first. And then when you're done, you take out the disc, you slide the tube out, the muscle fibers just come right back together, and you've done very minimal damage. You have to take a little bit of muscle right there at the surface of the lamina, but it's a fraction of the muscle injury, if you will. For a minimally invasive fusion, I do the same thing, except my incision, my portal's a little bit bigger. Instead of using a solid tube, I use a tube that basically has, it's broken into 4 quadrants, and I can adjust it at the top and move the distally, move down deep where I want to have my working aperture, and create the exact aperture that I want, but I'm still doing it through a very small incision. So to give you a perspective, I can do a fusion where normally we would do a big incision on the back. So, and the other thing you have to understand too, just real quickly, because we're working through a portal, it doesn't matter whether you weigh 100 pounds or 500 pounds, the incision's the same. So so people who are, you know, who are heavy, which that's not healthy, I'm not advocating that, but I'm saying if you're really big and heavy, you really benefit from a minimally invasive surgery, because I don't have to make any bigger incision on you than I do on a thin person. Whereas if I'm doing an open procedure and I'm trying to get down deep to do that work, well, in order to, the incision becomes longer and longer as the patient is deeper and deeper, because I've got to pull the muscles out of the way to get down deep. And so it really makes a big difference. Whereas an incision, an open incision, could be many inches long. A minimally invasive incision for a discectomy is 18 millimeters, as small as 14 millimeters, somewhere in that range. Some people use a 22 millimeter portal. It really doesn't matter. We're talking less than an inch. And when I do a single level minimally invasive fusion, like I did last week, I do that through a 40 millimeter incision. So we're still talking less than 2 inches. And again, I'm splitting the muscle fibers, and it typically results in a huge reduction in pain. It also typically, in most cases, results in a very minimal amount of blood loss. So for a typical open fusion, especially if someone, you know, has bleeding issues and their blood pressure is bouncing around, it's sort of a vicious cycle, because the more bleeding, the longer the surgery takes, because you're sucking blood. If the blood pressure is kind of bouncing around, and the surgery takes longer, well, as the surgery takes longer, then you lose more blood. But it's not unusual to lose, you know, 200, 300, 400 cc's of blood, milliliters of blood, on a single level fusion. And in fact, it's really not that unusual to lose 1,000. And so when I did a minimally invasive fusion, where I basically did a 360 fusion, where I went from the back and put screws in, and I did it from one side, unilaterally. This patient was a good candidate for this, and is doing quite well. I lost 50 cc's of blood. I lost 50 cc's of blood. That's 3 tablespoons of blood, versus potentially 1 liter of blood. And so there's a lot less blood loss. The surgery is in the beginning when you're learning to do minimally invasive procedures, probably takes longer than an open, but once you get proficient at it, I've been doing it for 15 years, more than most surgeons, you become as fast or faster. And a lot of it depends on the patient's pathology and how difficult the case is otherwise. But the big advantages are smaller incisions, less tissue damage, less blood loss, potentially less operative time, and all these things typically lead to fewer infections and better recovery. Now, I've seen typically young people are tougher and older people are, not, and minimally invasive should be less painful and open should be more painful. But I remember a 74-year-old that had an open procedure on once. She was up and out of bed ready to go home the next day. So you can't say 100% that everyone who has minimally invasive is going to be in less pain. I've seen young people with low pain tolerance apparently have just as much pain, maybe even more than what I would see with an open procedure. But generally speaking, for the most part, the minimally invasive procedure is a lot less painful. So preservation of anatomy, we're splitting the fibers, we don't injure them at all, except right where we're doing our work instead of peeling it down all the way from the top. Typically a lot less blood loss, usually less pain, and a quicker recovery. So those are the big benefits of minimally invasive. It's not a one-size-fits-all. Depending on exactly what the anatomy of the problem is, trying to do minimally invasive can be the wrong decision in some cases. And a lot of times if someone has had previous surgery and there's going to be a lot of scar tissue, etc., although I've actually found that I can do most people's surgery minimally invasive even if they've had a previous surgery. Not always, but it has more to do with how much of the canal is compromised. But what I'm doing is I'm doing a replacement for a 360 fusion, which in a lot of doctors' hands would be an open procedure on the back, many inches long. Do that procedure, flip the patient over, then cut a hole in their belly, move their guts out of the way, and then put their cage in from the front. I'm doing that entire surgery all from the back through a 40-millimeter incision, and I've done it more times than I can count. And so that, to me, is minimally invasive. And other people will do the same procedure from the back, flip the patient on the side, again, a second incision, and they're doing what's called an X-lift, where they do similar to that anterior procedure, but instead of having to move the guts out of the way, they come from the side, they sort of push the peritoneal items at that level out of the way. Unfortunately, there's a lot of cases of people with nerve injury that just get some numbness in their leg or some pain in their leg, and it usually goes away. But when I went to take the course years ago, they said, expect it in everyone. I was like, well, I don't think I'm going to do a procedure where I'm expecting a complication, and for at least for some period of time in everyone. But there's a lot of people that do that, and I think they're happy with that procedure. But again, it's 2 incisions. They're still doing 2 incisions where, I'm not doing a lot of surgery just for disc pain. So if someone's got a weak nerve or pressure on their nerve, numbness or tingling, they need to have the pressure taken off their nerves. That always means going from the back and removing a lamina and getting those nerves freed up. If you're just operating on people for only back pain, they don't have any nerve symptoms whatsoever, first of all, you shouldn't be doing that nearly as much as done, in my opinion. And that's really the only case where you can just go from the front or just go from the side and ignore the posterior canal. But I don't operate on people generally unless they need to have their nerves freed up. And in those cases, which I consider to be the more legitimate reasons to do spine surgery on people, you're going to end up with 2 incisions if you do it those other ways. The way I do it, I end up with 1 incision. I can usually deal with scar tissue from the back. It can be difficult, but I've gotten pretty darn good at it. I've done lots of revision surgeries, minimally invasive, through scar tissue. If someone's got complete occlusion of their canal, the disc is so big that it's just pressing on everything, I think open is the way to go. If someone has just severe scar tissue, that's the way to go. If someone has multiple levels, probably 3 levels, I'll do a 1 or 2 level through minimally invasive, you probably need to open up. You need to be able to see. So to think that minimally invasive surgery is a one-size-fits-all is definitely a big mistake. But anyway, I'll show you guys, I'll try to get maybe some pictures in the OR of the equipment. I actually did video a few minimally invasive surgeries. Again, I've been reluctant to put blood online, so you guys let me know. Maybe I'll send that out to the mailing list or the people who are truly interested. I'll make a special link and email that to them if they really want to see a surgery. I don't know, it's just been my opinion to not show blood, especially just not throw it on Facebook. It probably would freak people out. It's not, and even though it's really not that much blood, especially at 50 cc's, but still, it's bloody. Anyway, so minimally invasive surgery is wonderful. It's not for every patient. Every patient needs to be looked at individually. We still try to fix people with everything but surgery. Just because it's minimally invasive, it's still spine surgery. We still encourage weight loss, better nutrition, activity modification, pain management, epidural steroid injections, and things like that. But when minimally invasive surgery is indicated, it's an option. It's a wonderful option, and it works out really well for the majority of patients. And so, anyway, I just wanted to talk about that a little bit, see what the interest level was. A lot of people, see that I call myself a minimally invasive surgeon. What does that mean? Well, I've tried to explain that very basically. There's a little bit more to it than what I've said, but those are the basic. Those are the things that matter. Smaller incisions. And the incision is not really, that's probably the least important. It's what we're doing to the soft tissues after we make that incision that really makes it minimally invasive. It's the fact that we're losing a lot less blood that makes it minimally invasive, and that the recovery and the pain from surgery generally is a lot better with minimally invasive. All right, guys, remember, Facebook, Spine Center of Texas Facebook page. Get on there, join the mailing list, and win a free t-shirt. You guys have a great day.